Twitter session with the Point Counterpoint. My name's Alan Kaye. I am the immediate past president of the college, and I'm a private practice radiologist, sort of a hybrid version with academic, affiliated with a major institution, our own residency program. And so I practice in both in-hospital and outside situations. I'll begin this portion of the program with a brief discussion of the definition of steerage of radiology examinations, its rationale, its history, and its implementations, and how it's been implemented. Everyone is aware that the costs of healthcare have risen consistently over the years, a high-profile component of which is what we do, advanced imaging. A new industry arose with the intent of curbing the costs of imaging to payers and employers and patients, called radiology benefits managers. These brought to the table the requirement for pre-authorization, of which I'm sure we're all aware, for outpatient images and emergency room advanced imaging. Pre-authorizations have had a definite effect. For the past 10 or more years, patient steerage in radiology has been introduced and evolved. This supplemental cost containment strategy involves payers or their agents actively directing patients to certain imaging providers, usually on the basis of lower cost and usually to independent radiology practices. According to an informal survey by the RBMA in 2012, which is the last one of which I'm aware, 65% of practices reported experiencing active patient steerage by payers. With active steerage, payers give patients incentives such as gift cards, checks for choosing lower cost providers and or even do the scheduling of the exams. A more recent but now established factor in the mix is widespread responsibility of patients for their out-of-pocket costs associated with their care, co-pays, and even more impactful, the rise of high deductible insurance plans. Today, it's common to see $5,000 or higher deductibles. It's no wonder that patients are now concerned about the price differentials among radiology centers. Thus, in the same survey above, 47% confirmed the presence of passive steerage, simply making cost differential data available to patients and providers. By the way, the practice is most prevalent in the private health insurance market, as the cost differentials in the highly regulated Medicare and Medicaid markets are much smaller. If a generalization can be made, it is that largely because of their negotiating power, hospital prices are much higher than those of imaging centers and doctor's office in the private practices, private insurance setting. I'll now pass it over to Zeke, who will start the point counterpoint.
Yeah, Alan, I really appreciate you're sort of laying out sort of our landscape, if you will. Just to repeat a couple of points that you made, which I think are relevant. We need to acknowledge there is a payment differential between certain places, or what we call in the billing space sort of sites of service. So for example, for a single exam, there might be a higher payment in the hospital than a physician office. The process of steerage is utilizing that cost differential as a metric, as a motivation, as a reason, perhaps even as an excuse to direct a patient one way or the other. If that's the case, one other consideration, and I think you nicely stated, Alan, is that we're seeing more responsibility for payments from patients themselves, higher copays, higher deductibles, higher out-of-pay expenses. So last summer, what we saw was these sort of forces, if you will, these circumstances come together, and we saw a steerage policy come to the forefront. And it was from a particularly large insurer named Anthem in the United States, where that pre-authorization process, that steerage evolved from, as you said, from the outpatient setting. And understand, we've seen that since well before 2012. In fact, the ACR put a paper out in 2012 discussing steerage between outpatient offices. Imagine one physician office, lower price than another, and there being a motivated steerage to that center, the imaging center space, if you will. When it switched to the inpatient setting, the stakes perhaps became a little bit higher. And here's why that might be the case. Because now we had an entire site of service, an entire place of service, the hospital outpatient setting, almost completely unilaterally and overnight removed from the equation. In other words, patients, referring physicians, others no longer essentially had access to that particular side of service. From a cost perspective, let's acknowledge perhaps that's acceptable, perhaps that's okay. But I do think it's worth acknowledging, Alan, that in some communities, one side of service may be, and I'm going to say generically, better, preferable for different reasons. Maybe one side of service has been there longer. Maybe one side of service, just based on the evolution, has better resources, equipment, radiologists, referrals, parking, things of that sort. And if we acknowledge that there's a heterogeneous level of care across communities, then a broad stroke national policy that guides patients in every community, regardless of that circumstance, one way or the other, has the potential to have detrimental effects. If there's a community where the office does whether it's subjective or objective, a better job and patients are sent to the hospital, that might have negative consequences for the patient, and vice versa. So when the policy became public, again, this was about a year ago, we had to make a decision on what the position would be as a medical community. And just to introduce myself, since I was excitedly started talking. So again, my name is Zeke Silva, and I chair the ACR's Commission on Economics. I'm on the board of chancellors for the ACR, and I'm a private practice radiologist in San Antonio. I also have an academic affiliation with UT Health San Antonio. So very much at a national level, but very much at a local level, this is a policy that had potential consequences for those that I treat and also those that I represent through the college and through the specialty. As a result, I sort of had to formulate a policy. I sort of had to gather information. I sort of had to not just make individual decisions, but work with others like yourself, Alan, to make, and this was, you're still president of the ACR at the time, to make collective decisions, to decide what our position would be. One position, to be fair, would be no action at all. Just accept that the policy would diffuse in the community and deal with the consequences and the potential circumstances that it caused secondarily in sort of a reactive fashion. The other would be to proactively decide what the best approach might be and decide what we would do. And as you recall, and we're going to have this discussion today, we decided to gather information. We decided to request that the policy perhaps be slowed down a bit, maybe even halted. And that's kind of what took us to probably earlier this year, 7, 8, 9 months ago. And that's kind of what I'm interested in revisiting today to some degree, is not just your perspective, Dr. Kaye, but also the perspective of those that are following this through the tweet chat interface, to see one of the earliest actions that we took at the college was, he said, well, let's find out what's taking place out there. Let's gather some perspectives. Let's gather some stories. Some of those might be positive, some of those may be neutral, some of those may be negative. But until we had that interface, that interaction, that search, if you will, to gain that information, it was relatively hard to inform decisions. As you know, Dr. Kaye, we'll go back and we're going to revisit sort of what the ACR's collective stance in the last 2 minutes of this first 15-minute interface, video interface. But if I may, if I can, I want to turn it back to you, Dr. Kaye, and I've sort of presented myself so far some concerns that I have with the policy. I've expressed some potential shortcomings that I thought could have very real consequences on individual patients. The one thing I didn't mention, but I'm going to close by mentioning now, is if you're any entity, and this is the ACR, this is Medicare, this is one of the largest private insurers in the country, a hospital, a radiologist, any individual or entity is going to make and create a policy that has potential downstream consequences, it would seem appropriate to evaluate what those consequences are prospectively beforehand, rather than hearing and reacting to them later. So one concern that I had last summer was the fact that I heard about this particular policy with Anthem purposefully steering patients from an inpatient to an outpatient setting. I actually heard about it weeks into the policy being put into effect. And to be fair, I mean, I'm not the most important person in the radiology space, but I do have some influence and I do have some experience informing those discussions. And I thought, and we'll close with this later on, but I think one responsibility we have to maintain is that if we're going to have this policy in place, that we need to collaborate collectively at multiple levels to ensure it's done as properly and safely as acceptable. Back to you, Dr. Kaye.
Thanks, Zeke. I don't want to sound like I'm an apologist for steerage. And in fact, I kind of kept my comments more general with respect to steerage than specific to the anthem policy. Uh, because really, where it should start is the philosophical discussion about whether steerage is appropriate or not. And if so, how and why and what process. And clearly, the anthem process of unilaterally announcing it. And remember, this isn't really steerage. I mean, this is steerage with steroids, if you, pardon the alliteration. It's uh, it's non-coverage. They came out and said we are not going to cover outpatient imaging in the hospital setting. And as soon as I saw that, and it was again maybe a day or two after you saw it, when we discussed the policy of the ACR, it was it was already in place in certain places. So I think this was my impression. I have a lot. I actually was once on the radiology advisory panel for Anthem. I think this was an exasperation to the fact to a sort of a last ditch effort to make something that was unacceptable and not sustainable in order to bring the issue to the forefront. So that said, I don't want to be an apologist for steerage. In fact, I'll relay with you is what's happened early on in the steerage in my setting, which is one of my roles as an outpatient imaging independent provider. Uh, we saw that patients for $100 difference in price were being diverted from a referral to our 1.3 and 3 Tesla high field units to a 0.35 unit uh, 10 miles away. And when I called and asked them about it, they said, well, you're both A scanners in our rating. And I said, well, how does each of these become an A scanner? Well, they both have ACR accreditation. And now, obviously, as a leader in the ACR, although not at the higher level that I ended up being, I was sort of, uh-oh, what have we done here? So it is clearly not appropriate in many situations to steer. But on the other hand, we do have some cost issues, and I'm going to try and talk about them. And the situation has improved on those egregious things since then. The real bang for the buck these days is between hospital-owned centers and independent imaging centers for non-government payers, where sometimes the differential in negotiated fees, not not the fee, the fee that we ask for, but the actual fee that we're paid is usually 2 to 3 times, and sometimes up to 5 times difference for an MRI for all price per RVUs. But MRI is obviously, with the big dollar, is magnified that much more on an absolute basis. But another type of steerage, and I think the one that probably exasperates the payers mostly, is frequently overlooked in these discussions of steerage, and that's steerage by the providers themselves. We all are aware of the consolidation among hospitals, the purchases of medical practices by hospitals, thereby forming large integrated oligopolies at best, monopolies in certain situations, integrated health systems. In these situations, the hospitals are able to control the referrals made by the physicians they own. It can be by carrot or by stick, bonus criteria, contractual language, coercion, or just the knowledge that Big Brother's watching. A less recognized way of controlling referrals is through the electronic health records, which became a big issue in the last 5 years, whereby Congress gave an exemption from Stark laws and allowed hospitals to donate EMRs and the hardware to physicians in the community. This was meant to foster interoperability and communication exchange, but they can also be used to thwart external communications and referrals, and are. Subsequently, Congress heard about this and asked HHS and the Office of the Inspector General to look into it, and they came out with a landmark document called Report on Health Information Blocking. It was a scathing condemnation of these practices and called for congressional intervention. That was followed by the 21st Century Cures Act, passed by Congress and supported by the ACR. Unfortunately, progress has been slow. Non-enforcement, non-compliance, and loopholes in there like the Stark had that basically meant that still there are big bucks at stake here with respect to $3,000 MRI fees, for example. Most radiologists, we're mostly hospital-based, and we're pawns in this battle. Private practice radiologists generally negotiate and bill separately for professional services, and those fees are not in the same stratosphere as the hospital rates. Academic radiology departments are able to negotiate a little bit better rates than private practices, but still are not at the level of their hospitals. Yet, when payers steer patients away from hospital sites, we lose, because if as a hospital-based radiologist, we don't get their work. How many radiologists will go to their hospital CEOs and demand or even suggest that they lower their rates to be competitive? Maybe the ACR can help, and this is where I think we are appropriately gung-ho on patient-centered care. We even have a patient and family-centered care commission with a seat on the board of chancellors. With high deductible plans, patients can exhaust their entire deductible with a CT and an MRI at one hospital-owned facility. Medical bankruptcies are a problem, but their numbers are dwarfed by the surprise when they open a bill that shows that they're responsible for $3,000. We need to walk the walk on patient-centered care, in this case regarding inappropriate charges for technical components. This could be an opportunity for the college to represent our members and our patients in an open dialogue with hospitals and payers to meet somewhere in the middle. Thank you for that rush through rationalization. Zeke, it's up to you now to see if we can meet somewhere in the middle.
We're gonna sort of wrap up the video part of this. We're gonna try to do it at the quarter of the hour. I'm just gonna close out with a couple of points, and if I may, is I think what we've hopefully shown is that this is not an easy discussion. That steerage and the importance of appropriate, responsible acknowledgement of cost is very real. It's very real to multiple levels, from the highest levels of the Medicare program to large private payers, to large institutions, to employers, and to patients, and to be clear, to radiologists and imaging professionals. I hope we today, for the next 45 minutes or so, can really hear some very different perspectives. Here's how this has affected individuals on the ground, how it's affected individuals, not just as radiologists, or maybe not just as professionals, but as citizens, or dare I say, as patients, or family members of patients, and really see if those discussions and those perspectives can inform our actions going forward. I will say, and I'm going to close with a very quick ACR plug, and ACR perspective is, the ACR's approach the entire time is to ultimately do what's best for patients, and to ultimately do what's best for those taking care of those patients. We represent radiology, so I can't act like we're not looking out for our own, because we know how important our contributions are. But our goal is to do that with the absolute responsibility at hand, to do that in the most responsible manner possible. I will say that we've talked about events a year ago, 6 months ago. I will say that the climate has changed favorably. We've had favorable interactions with the American Medical Association. We've met several times with the Anthem representatives themselves. We've actually interacted with other private payers and other entities, if you will. So the positive discussions are going forward. The acute nature of what we saw a year ago or 6 months ago has improved. And I think it's been a real pleasure to participate in this forum. Dr. Kaye, we'll be digital here for the next few minutes, but I want to thank you for your leadership. I want to thank you for your time and certainly for your friendship above all else. I'll close and I'll turn it back to the organizers, and thank you very much.
Thank you very much to both Dr. Kaye and Dr. Silva for their points. And we will now turn over to Twitter for our normal tweet chat. Thank you very much for taking part today.